time. So just welcome all. Hope you're all here for the non-medical prescribing update that Joel Hannon, who is the NMP lead for Bolton, is going to present. We did have about 35 minutes, but I now think we've got about 25 minutes. So you're okay with that? That's brilliant. And how do you want questions to go? Do you want people to put their hands up, or do you want them going in the chat? And if we get time, we'll come to them, and if not, answer them after.
Everything. Chat, questions, people shouting out, hands up, abuse, whatever suits for everybody.
Perfect. So I shall just leave it to you now. Thanks so much, Joel.
See if this works. So can everybody see that opening slide?
Yes, we can. Thank you, Joel.
Wonderful. So just as introduction, if anybody wants to put on their camera, I know this is being recorded, but speaking to a blank screen is always soul destroying. So if anybody would like to do that, help me out so I know whether I'm talking to a load of empty chairs or whether people are actually taking part would be good. So I'm non-medical prescriber for the Bolton locality. Asked here often, your non-medical prescribing leads are struggling to find these areas and to attend. So I was asked to speak about the challenges of changing prescribing. But even better than that, I was asked, could I cover a question that somebody sent in? So as I said, anything on chat or anybody want to ask. It was from, I haven't been given which area, but a CCG have not provided training for this. I take it that's NMP training, even though it's part of their policy. Are employers responsible for this, or is the responsibility that of the clinician? Now, I'm really happy that the way that ended there, because that's driving towards the answer. Because I haven't got enough minutes, I will cut to the chase with this. When it comes down to your professions and when it comes down to the focus, most recommend that actually it is the individual, it's the prescriber that's responsible, and that comes from your professions. So the NMC with the prescribing qualification recommends that actually the individual is important. CCGs, so the policy now actually finishes with that. We've got to the past the start of July, so CCGs no longer exist. We are now part of the integrated care for Greater Manchester. This might change. So what I'm saying at the moment is where we currently are, what we know, which is, please can you carry on as you were before while we make sure we know exactly what's happening. So if we get together as a GM area and decide non-medical prescribing will change, and there are views to try and make this global, so whether you're in foundation trusts, CCGs, whatever your provider, actually, we want you to all work in the same way. That's great to talk about, transitioning from where we are to where we need to be. And also the responsibilities are really difficult, so that may take some time. But I've looked for many different areas, for some areas that have already moved into CCGs on the footprint of what their integrated care systems are going to be, and all still having their recommendation that the employers and the prescribers are the focus. So from this, wherever you're working, if you've got a guideline that covers you, you're quite lucky. I know it always feels like it's really, really challenging and going above what needs to happen, but this is just to evidence all the things that we can find that your profession has recommended or that other people have recommended. So the guidance says if you fit all of these criteria, we think you're set. In that case, if you've got a CCG that has criteria that says attend our training events and they're not doing training events without letting you know why, obviously within Bolton, our training sets were due to be January. You can imagine that basically the 2 Januaries that we had were virtually in the middle of 2 spikes. So dragging out a load of staff that could vaccinate was being asked to say, actually, we're not very happy with this. So we've had to change how things go, but we still put out information and support there. So all of this policy should support you, but it only goes back to what the NMC have actually said you need to do as prescribers. To support you further, as NMPs, hopefully you've got a clinical supervisor. Now, there's different terms used in different areas. That may be your ongoing DMP. It might be your DPP now, so your designated prescribing It may be your employer or your manager, or it may just be, if you're a part of a single-handed practice, you're talking about your lead GP. So on those, these are your point where you actually sit down and talk. There are different ways of doing this, whether it's your one-to-ones, your appraisal, or just your plan for your revalidation. There's lots of different ways. Some people just have a sit down with their manager and say, in the next year, I want to develop my skills in this area, or I want to reskill on this, or I want to go back and recheck what I'm doing. Just a warning, events like this, even though they are about engagement and NMP, they're not designed as educational, continuing professional development as such. So if you say I attended one of these every 2 months, and that's me now fully up to date as an NMP, you just have to look actually what areas you're working in, what training, what CPD you're using. So this isn't designed as a attend this and you know everything. This is basically an engagement where you need to go to next rather than covering everything. Education events, if they're aimed as you as an NMP, obviously can be used. But again, these sort of touch base events will never go into the depth that you need to basically cover all of your non-medical prescribing. So just a warning there, if you tick this off in your list and say, this is me covered, you might have somebody asking, can you do something more, or actually, is this proof that you've got the scope of competence that you need? When I was looking through if we've got any advanced nurse practitioners or advanced practitioners, I really like the way their guidance talks about competency and also capability. So if you're looking at this, if you are already there, your competency is very basically what you can deal with at the moment. You know, what you can do, what you can deliver, what's within what you can actually do safely and appropriately. And your capability is looking at actually what's the next step. So when you've got the patients that you see that you have to hand off to another service, that you know your competency doesn't stretch to that. So whether it's somebody who's, you know, too ill for what you offer, whether they've developed, you know, there's more complexity in their dual diagnosis, all of these things that come along where you say, right, this is at the end of my competence. The capability is there. Actually, is this happening a lot? How do I then stretch my experience to that level? So again, you can't really do the training for that. That's something that you pick up as a professional within the service that you're working with. Oh, so I've got Jed Lancaster with a hand up, so that's wonderful. So I'll stop because I love listening to somebody else other than me.
Hiya. Can you hear me okay?
Yes.
I just wanted to ask about formularies. This
Lovely.
is like a thorn in my side at the moment. So I have a contact who, when I initially did my NMP training, I sent my formulary to and I got a nice email back saying thanks. I'm not really sure what actually happens to them. Somebody in meds management or something like that we have to send them to. And obviously we're told throughout the course that we have to keep them up to date. So dependent on how your skills develop, if you then start to prescribe drugs in a different group, you need to add them CP formula and send that back off again. But I've just started the ACP course a few months ago, and now I'm kind of thinking this is a lot of work to try and keep every single drug that I'm prescribing on this formulary all the time. And I'm just wondering, is there a better way to do it? Do I still need to keep doing that all the time, or I'm just not really sure what I need to do?
So it's always a challenge. formularies are one of these where do you record separately paracetamol liquid, tablets, you know, soluble, you know, you could go on and on and on for ages. So part of this is discussions with your employer or what actually goes through, but also you bringing that back as a professional to say, what would support me? So if something does go wrong, because often many things go wrong with medicines. So, you know, if they're misused, you know, prescribing, the identification isn't correct. So what supports you to give you the evidence for what you've done? So most areas now are sort of moving towards a scope of competence rather than just a formulary. So with that would be actually, I am competent in prescribing for diabetes. So that's often what I see in a scope of competence. Often if you challenge yourself, is diabetes a thing? And it's not usually a thing. Usually you're competent for, is it type 2 diabetes? Is it the first couple of steps? How would you hand that off to the next patient? So it's trying to use that scope of competence to support you with where you see you are competent. So some people will say, actually, you know, there's 5 inhalers that I really know inside and out that I recommend that I use. That's all I'm going to do. So formulary works for that. If you see the link that I put before in the title, there's 131, I think, different inhalers currently. So if you say I'm competent in asthma and COPD and all of the inhalers, almost you can't be. You know, there's that many different ones. Do you know what's in them, the combinations? So it's balancing that back. But normally sitting down with your employer, whoever is taking on that clinical support, having that discussion with them of saying, how do I evidence where I am? Normally, if you check back through what your NMP policy actually says, hopefully it's got a section which is scope of competence. And that will fit, certainly as you go to an ACP, far, far better. But again, it's that evidence that you're using drugs that you know about, you know how they interact, you know what goes on. It's that balance that you've got to decide, actually, what do I need for the evidence, for the interactions, for the indications, so I know I'm prescribing legally, for the use, for the dosage, all of these things. How are you going to get that support for yourself when you do get that widened scope of work? And the scope of competence is good, but please don't throw in, you know, I'm able to prescribe everything in the BNF. Because if something does go wrong and you're challenged on it, they will automatically pick something you've never heard of and say, what's your support on this? I know that's a really negative way of looking at it, but it's that trying to cover yourself to say, actually, I do know the detail of this group and I'm really happy. And then talking about that capability as you go forwards. Does that make any sense to you in a practical basis, or have I just prattled on for no reason?
Yeah, but it still sounds quite complex though.
It comes down, unfortunately, if you want to make it really, really easy, it's go back and do a medical degree. So the only way that this is sensible is if you are a medical degree, because it's almost like if you're you know, buying a car, you know, you buy it outright when you get your medical degree. You know, that is your experience, your knowledge, your competence is proven by you getting that. If you're a non-medical prescriber, you are paying it in installments. So with that, you have to basically go back, and instead of giving them the money, you have to give them the proof of every time, yeah, I can still drive this car, I can still do, this is my down payment on an annual basis to show that I've got those skills there. And it's not just I passed my NMP qualification 20 years ago, I can now carry on as normal. And part of this is defensive for yourself. So when a complaint comes in, when something happens with a patient, you can then go back and say, look, I'm well trained, I knew exactly what I was doing, and I've got the evidence. That's what I'm asked to do by the NMC. That's what I've done. But it's trying to shape that to the areas that you're working in and trying to get that. And that's a really good challenge for anybody who's doing your lectures at your course. It's what does a real life advanced nurse practitioner portfolio look like after 5 years when they are taking on huge amounts of prescribing and responsibility. So please challenge them and get them to come up with the best things, half a dozen different examples, and then you can take one of those with you to go forwards. But definitely P-formulary and individual drugs, I don't think you can.
Okay, thank you.
As I said, it probably flows into that, the competency documents or your scope of competency. If you're an asthma or COPD and respiratory nurse, that's your aim in practice. Would you initiate someone on an antipsychotic? And the chances are that I'm hoping that you wouldn't, because it's way outside of your competence. Can you review that? Do you know what the drug is doing? But then there's challenges for people that work in practice. If you're fully trained in the systems of the practice, would you consider a reauthorization of a medication? If it's an antipsychotic, many people would say no, not even touching it. If there's a really good care plan on that patient with really clear defined outcomes, consultant saying I'm seeing this patient in a year, as long as their blood say X, Y, and Z, and you can check all of that, would you? So again, that comes into the discussion with your employer. Many good employers will say, steer clear of that. You don't need to get involved. We are wanting you to do your job, not trying to do other people's. A GP can do that on milliseconds. We don't want you spending half an hour trying to work out how to do that. And it's those type of discussions of actually, could you? Yes, you could. Are you the best person placed to do that? So that comes back down to those discussions that you can have with your employer to say, let me see 100 patients on asthma. I can do that in the time that I could reauthorize 3 patients on something that's outside of, you know, what I'm happy with. Which do you want me to do? And often that comes down to that really honest discussion with the practice and the discussion. If you do want me to go to this level, I need to be trained. I need to know what I am. I need to be skilled up before I start doing it. I know the NHS loves to throw people in the deep end and say, don't worry, we'll train you after you've done this for a year, or the training's coming and it never does. But it's more important with that. This is your professional reputation. This is what the NMC will challenge you on. It's part of those discussions to say, let me do what I'm brilliant at. Let me do what I'm superb at. Train me up to do something different. And again, challenging. That's why you go back and speak to the non-medical prescribing lead and say, I've been sending off my P formularies for the last 6 years. Can I have some support back, please? And that's what they should be there for, saying how that policy and information supports you. So no more hands up. Yeah, so I've bored you all with my answer to Jed. So apologies for that. More hands, please. Otherwise, we'll get on to changing of medicines and prescriptions. So the main part of this, most people, especially when you go through your university qualification, it's about new initiations. Everything's this brand new sparkly patient who's got a clear diagnosis, and you're choosing what item to go forwards to. The challenge that we get to often is when actually somebody's on something and you want to take them off that. So actually stopping a prescription is as important and as valid and as much as a prescribing decision as starting somebody on a new medicine, which is why often people aren't stopped on medicines, because you almost have to know more about that medicine to stop it than you do to start one. So how do you develop the competency for this? You're looking at actually, do I know both medicines? So really, really simply, actually, do I know everything that's going on here? If you don't, your simple steps are what support is there within practice. So often, have you got a medical prescriber on site? Talking contractually, that should always happen. So you've got somebody to hand off when it gets beyond your scope of competence, beyond something you can do, or so you can have a second check. Hopefully that's happening in the sites that you're in. If it's not, speaking to a couple of others, to see actually how you get that support put in place as part of your annual review, as part of the support that you need. Often if you're within a trust, it's really, really simple. If you're working on a ward, somebody says, can you prescribe this? It's a very easy handoff. No, it's got to go to one of the medics. It's got to go to somebody else. It's not that level. Primary care should be no different. You know, lots of practices put in processes around repeat requests. Posters stuck up. If you want to repeat, ask at the front desk, order normally. Don't just actually ask as part of your clinic, because you're here for a clinic, not for part of your repeat requests or a new initiation. Really difficult to do. If your practice doesn't believe in that, if your practice thinks, yes, pile it onto the GPs and prescribe, we can do anything, we can do everything, is that discussion to say, no, we're a bit normal. You know, we are, you're employing us as an NMP, not as a doctor. Actually, we need that support. We need those handoffs to other areas. So if we're not being asked to do referrals, you need that plan in place for actually, if it is suitable for a referral, how do you take it on? If it is suitable for a medical follow-up, how do you pass that patient on? They're asking for a medicine that's outside of your scope of competence. How do you then pass that on into the system to get that done in the normal way? Again, often part of that learning is the patient doesn't actually make it to your clinic for that request. So if you've got a really good system, it's there going, actually, I've had 5 patients asking for a drug that I'm not supposed to be playing with. Why are they getting onto my list? I need to get the patients that can see me and benefit from me, not the patients that you just need to find a home for. So that can be a really difficult discussion. But again, it goes back to your clinical supervisor to say, I need appropriate patients to support me. And if you are changing, you get to the point where it is within your scope. Do you know the previous item and the new one? Things change so often. Again, your professions say, and all of the guidance says that you need to know. So if you're specialist in diabetes and you see a drug come in that used to only be used in diabetes, warning, lots of them are now transferring across into weight management. So hopefully that'll be under specialists, so it's not touching you. But then you also get patients who have CKD who are now on treatments that is for diabetes. You also have heart failure that are on treatment that we associated previously only with diabetes. So again, stopping one and starting another, you need to know why. You need to know the ins and outs of that drug. Are you sure you know the criteria for why that was started? So again, with these dual usage medicines, when you get onto asthma and COPD, if you've got a dual diagnosis, it can be really tricky to get your head round. So making sure they are on the right registers, you do know what the diagnosis is before you stop one of their treatments. And getting on to, I know many people probably will have been caught between this and the menopause discussion, because we need as much information, and I'll be going away and reading and watching the group on menopause. When you have shortages in this, I've come across many areas where it's just, oh, it's only a change. I'm on estrogel, just give me something different. Sadly, we live in a very sexist situation, so often it's a female nurse, it's thrown to them saying, you come up with an idea for us. One of these is, again, it's dealing with those, how do you put off those decisions without trying to absorb it all? Even the most experienced GPs at the moment are stuck with this. The amount of guidance out there is contrary, it's not clear, often it's going outside of license. So again, it's where we wouldn't have previously gone to. But again, it's how do you deal with that? And sometimes it's just the skill that you have yourself saying, I understand, I'm going to take down as much details as I can do, and I'm going to get back in touch with you. So again, you're not forcing yourself into that position. You're giving yourself that space to say, it's really important that I get the right answer for you. I need to go and ask a few different people to get the right answer. I can't do it straight away. Really common with some of the very good GPs that I work with, less so with the NMPs, because of that feeling, actually, I need to make the decision here and now. So sometimes that pause of a couple of days, can I find out the information? Can I get that support? And again, often when it comes to HRT, it will be passing that on to a GP, because actually you don't have the time to skill up and basically stretch that into areas where you're not fully competent with. If you do HRT and you do well woman clinics, then people will be absolutely going to you for all the advice that they could possibly want. But again, it's knowing where that competence lies. Testosterone is dreadful. I wish they could just bring out a licensed product that worked for this, and it would make everything far easier, far cheaper, far better for women, far better for prescribers. But that's a dream. So with these items being used outside of license, very sort of not clear guidance that's out there. And sometimes if you read two pieces of guidance, you can't put them together. That's a challenge. So do think, actually, how do I support this patient, but also get the best care for them? And it goes with inhalers, talking earlier on with the presentation. If you do dry powder inhalers well with asthma, you get it cheaper, you get it better, you get it clearer. But as I said, there are 131 inhalers out there that cross over COPD and asthma. So knowing what you're doing, knowing how to stop one, knowing how to start one is absolutely key. Knowing that you're switching from a similar to a similar can be really challenging. So again, it's making sure that's within your competence. If you need that time to say you are interested in dry powder, but what you're on is a bit confusing, or I haven't got an instant answer, again, put that off. A QRX message to the patient when you've got that sorted, when you've had time to sit down and actually work it out. Give yourself that breathing time. Can only be a day or two. Again, it's not going to change anything significantly, but you could just say, right, next time you come in, I'm going to train you up on these inhaler types, or you're already using this inhaler, I'm going to switch you to one as a combination. That gives you the support. And again, unfortunately, I'd love to say a different message, but your professional standards expect you to keep up to date with guidance. This guidance is changing on a weekly basis. So as part of that, where it's worthwhile just to basically say, right, actually, if you haven't updated in the last 6 to 12 months, you might be missing something. So it's part of that development, but also that part of where do I go for my best answers when I've got the patient sat in front of me. So as was mentioned, there's the GMMG guidance on inhalers. Hopefully there will be soon for HRT and the options that are there. But then when it goes outside of guidance, what do you do? Who do you reach out to? In my local area, we push people to medicines optimization team, throw us your questions, we'll come back with the answers. But again, that's not instantaneous. That's not within, it's usually within the day, but you don't want your patient waiting around your clinic room for that. So again, if you can, give yourself that breathing space with the patient if you're not sure. If you are, absolutely should be within your competency, within your P formulary. You should have that list and you should know what you're doing. If you don't, take that step back. Sadly, no more hands up, but I think I've spoken so quickly, I've got to the end of what I was going to say anyway. So any questions before we're whipped back into the main room?
There's something just in the chat as well. There's a survey that's been sent out to for us to circulate around all NMPs, and it's basically to try and help understand current NMPs, what they might need to confidently undertake the GPP role. So that's, somebody's very kindly put that in the chat. So if people do want to fill that in, I think it's quite a short survey, then that'd be really useful. There's a deadline of the 25th of July for that. But thank you, that was really useful presentation, and you managed to get through that in the short space of time, so that's fantastic. I think they must have extended it slightly, so if there's not any other questions, I'll just give people another minute or so, then I think we can press that return button to get back to the main room rather than having to hang around. But if it goes completely belly up, then we have to just go back to the first link you came in with. Oh, there we go, got some messages in the chat now.
Well, we have a couple of seconds. If anybody's got something they would like to prompt for next time, questions are far better to direct than what I think is good. So we've got one there, annual education NMP updates. So usually that would be via your locality. So your old CCG, whoever's classed as your NMP lead, can I just check that was from Jed? Which area are you in? Ancoats Urban, is that Manchester CCG?
Yeah, we're just outside of the city centre, but we actually come under North Manchester. We're a bit of an odd one because we're in the boundary of the city centre, but come under North.
So I'm desperately trying to think. I haven't got the list of leads, but I will see if I can.
I know who the lead is, but
So
I've never had any communications from them about any sort of updates.
So checking that, and also do you have any, is there any nurse discussions, nurse groups, practice nurse groups that are run by your, well, what was CCG? Tripping over my lack of knowledge of who I am.
Yeah, just these ones.
So if you I shouldn't really be saying this, but if you have a job in Bolton, come along and we'll do some training. Leslie will absolutely kill me for saying that. No, it's worthwhile raising.
I've seen some private ones, like with MK and Update and places like that. They're quite expensive though, and I don't think my employers would. And whether they're accredited or I don't know. I don't think they'd pay the money.
It should be laid out in your NMP policy on what the CCG are going to do. Now, if they've been really harsh, they will say that actually the training is down to you and your employer. But many areas offer this above to basically try and support NMP so they can prove they're at the level that they are, and so they can provide that evidence. And again, that helps everybody. Yeah, so Salford CCG a message in there as well. I think we're going back to the room now. But bother your NMP lead and ask for support.